Hello everyone. In this class, we'll learn about the changes that occur during pregnancy. Physiological changes that occurs during pregnancy. There will be changes in the uterus. Uterus increase in weight from 30 to 60 grams in nulliparous women to 800 to 1000 grams at full term, and this occurs due to the hypertrophy of pre-existing muscles mainly, which both occurs in width and length and by approximately 5 to 9 times. Also because of the increase in the amount of connective tissue and elastic tissue between the muscle fibers. All these effects are seen during first 2 to 3 months of pregnancy due to estrogen. Subsequent enlargement of uterus is due to the growing fetus and causes uterine wall to become thinner. Changes that occur in the body system and organs, like in the blood volume increases by 30%, that is 4 to 5.4 liters, and this occurs mainly due to the increase in the plasma volume. Therefore, RBC count, packed cell volume, HB concentration during uh, decreases, producing anemia, and it is called as physiological anemia of pregnancy. Its characteristic features are iron deficiency anemia, as iron demand increases during pregnancy. On plasma proteins, total plasma concentration decreases, serum fibrinogen increases, which increases the ESR, and serum albumin decreases, but the globulin concentration increases. Changes in the heart enlarges due to the pressure effect of enlarging uterus on the diaphragm. Cardiac output increases up to 5 to 6 liters due to increase in the stroke volume and the heart rate. Systemic blood pressure, both systolic and diastolic blood pressure decreases. The antecubital venous pressure is normal. Femoral venous pressure increase due to the pressure enlarged uterus on the pelvic veins. Blood flow through the hand and forearm increases. This increased flow helps in loss of excess heat produced by increased body metabolism. Effect on respiration, vital capacity. There is no change in the vital capacity uh, due to the upward displacement of the diaphragm gets compensated by increase in the width of the pleural cavity, whereas pulmonary ventilation increases due to the increase in the tidal volume and frequency of breathing. This may be due to increase in the progesterone level, which increase the sensitivity of respiratory center to carbon dioxide and cause fall in the arterial PCO2. The body oxygen consumption increases by 15%. Their action on GIT, that is, there is increased morning sickness, feeling of nausea and vomiting in early months of pregnancy. So there can be hypochlorhydria, there can be decrease in motility of the stomach and the colon because of the effect of progesterone. Effect on the urinary system, renal blood flow and glomerular filtration rate increases in parallel with increase in cardiac output. There will be increased GFR, which lowers the solutes presented for reabsorption, and this may account for the glycosuria of pregnancy. If you see the effect on endocrine glands, thyroid gland shows mild enlargement with hyperplasia and increased thyroxine output, but there are no signs of hyperthyroidism. Adrenal cortex shows enlargement of the zona fasciculata, a layer in particular, therefore cortisol secretion increases, but no signs of Cushing syndrome are seen. Placental hormones are secreted. The effect on the nervous system shows mild mental changes which vary from craving from unusual articles of diet to alteration in the mood and behavior. In some, a true psychosis may also develop. There can be changes in skin. Skin shows pigmentation of nipple, breast, areola, and linea alba. Brownish patches on the face and the neck also develop, and these changes are due to the oversecretion of ACTH and melano, uh, melatonin stimulating hormone. The metabolic changes that occurs during pregnancy. During pregnancy, there is a marked increase in the body weight on an average 12.5 kg. So there will be alteration in water metabolism. During early months of pregnancy, there is marked diuresis, sweating, and a weight loss of approximately 2.5 kg. During later months, that is around 5 to 6 months onwards of pregnancy, excess water is retained in the fetus, placenta, amniotic fluid, breast, uterus, and tissues. The retention of water is due to the fall in plasma protein concentration, especially albumin. Thus, the colloidal osmotic pressure decreases. Retention of sodium due to the steroidal sex hormone occurs. Protein metabolism. There is a positive nitrogen balance during pregnancy and during the lactation period. On carbohydrate metabolism, renal threshold of glucose decreases during pregnancy, producing glycosuria. On the fat metabolism, there occurs increase in blood concentration of cholesterol, phospholipids, and neutral fats. Adipose tissue fat increases to supply energy in the later stages of pregnancy and lactation. On the mineral metabolism during pregnancy, the mother stores approximately 50 grams of calcium and 35 to 40 grams of phosphorus. Only half the calcium goes to the fetus, especially during the last month, the rest being stored in the maternal tissues to be utilized during lactation. Effect on iron metabolism. The fetus contains 375 milligrams of iron, which accumulate at the rate of approximately 0.4 milligrams per day in the first 6 months of pregnancy and about 4 milligrams per day during last 3 months of pregnancy. A further 500 to 700 milligrams of iron is required by mother for increased hemoglobin synthesis and myoglobin formation in the growing fetus. The iron in the newborn child and iron removed in the blood lost during delivery amounts to 400 to 500 milligrams. This represents 1/8 to 1/10 of the total body iron and must be compensated by increased dietary intake of iron during pregnancy. Some of the pregnancy tests which are done which based on the earlier bioassay methods, which is called as Asim-Zondek test, where the urine of the woman suspected to have developed pregnancy will have HCG. So this HCG, when injected to immature mice, the animal which do not ovulate naturally due to its immaturity, will cause ovulation, so which can be detected. Then some of the immunological tests are the Gravendex test, where principle is the HCG, being a protein in nature, will cause generation of antibody when injected into the suitable animal. The HCG is injected in rabbit, in whom antibodies develop in the serum, which are called as rabbit antiserum, and rabbit antiserum is then collected. Small globules of latex particles are coated with pure HCG, and the urine suspected to contain HCG is now treated with rabbit antiserum. If the urine contains HCG, the antibodies in the antiserum are all used up. Subsequently, when HCG coated latex particles are added to the mixture, latex particles do not agglutinate, whereas if urine is free from HCG, the antibodies in the rabbit serum remains free. In such mixture, that is where the suspected urine contains no HCG, when the latex mixture coated with HCG are added, antigen antibody reaction between the HCG of latex particles and the antibodies of serum occur, and the latex particles are agglutinated. Therefore, agglutination of the latex particles means that urine is from non-pregnant woman. Apart from diagnosis of normal pregnancy, this test is also used to diagnose some diseases of placenta. Okay, so this is how test is performed. If the urine contains HCG, so when HCG antiserum is added, neutralization of the antibodies occur. Later, when latest particles are added, there will be no visual agglutination, so that indicates the presence of HCG in the urine. When urine contains no HCG and subsequently HCG antiserum is added, there will be no neutralization, and these HCG will form agglutination with latex particles. So there will be visible agglutination scenes, which confirms that there is absence of urine HCG and absence of pregnancy. Coming to placenta, placenta is also called as fetal lung. It mainly consists of maternal part and fetal part. Maternal part is called as decidua, in which large blood vessel sinuses partitioned by fibrous septa are present. Maternal blood circulates in these sinuses. Fetal part, it consists of numerous finger-like processes called chorionic villi. These project into the maternal blood sinuses. Chorionic villi has two layers, cytotrophoblast and syncytiotropoblast. Syncytiotropoblast produces all hormones. Oxygen is taken up by the fetal blood and carbon dioxide is discharged into the maternal circulation across the walls of the villi in a fashion analogous to oxygen and carbon dioxide exchanges which occur in the lung. Some of the functions of placenta. They have a respiratory function, that is diffusion of oxygen and carbon dioxide through the placental membrane occurs. They have an excretory function, that is it helps in the excretion of the waste products. They have immunological functions. Many immunoglobulin molecules IgG from maternal circulation cross placental barrier to confer a passive immunity in the fetus. And many drugs also cross placental barrier, for example pethidine and anesthetics. If used in labor, these drugs cause damage to the fetus. Some of the endocrine functions are a fetoplacental unit which produces many hormones vital to pregnancy. Hormones produced by placenta include HCG, human chorionotropic somatotropin, that is HCS, and human chorionic thyrotropin, that is HCT, estrogen, and progesterone. So this is the structure showing placenta, which is showing the fetal side and the maternal decidua. In the fetal side, it mainly shows the chorionic villus, chorion, and amnion, and the maternal side mainly shows the uterine vessels with the sinusoids. The hormones which are presented by the placenta, they include human chorionic gonadotropin, which is called as HCG, and human chorionic somatotropin, which is HCG, human chorionic thyrotropin, which is HCT, estrogen, and progesterone. Human chorionic gonadotropin. So this is a placental hormone. It's a glycoprotein that contains galactose and hexosamine. It is produced by syncytiotropoblast, and HCG is primarily luteinizing and leukotropic, and it has a little FSH activity. The HCG is detected in the blood at 6th day after conception and in the urine after 14th day. It appears to act on the same receptors as the luteinizing hormone. Clinically, HCG is not absolutely specific for pregnancy. Small amounts are secreted by variety of gastrointestinal and other tumor in both sex. That is HCG as a tumor indicator in them. Functions of HCG are: it maintains the corpus luteum of pregnancy, it increases interstitial GH, leading to testosterone secretion which promote development and descent of testis. It also helps in development of stromal and decidual cells. Whereas HCG, HCS, that is, it is synthesized by the placental syncytiotrophoblastic cells. It resembles growth hormone in amino acid content. It is maternal growth hormone of pregnancy. The amount of HCS secreted is directly proportional to the size of placenta. Therefore, low HCG levels are signs of placental insufficiency. HCT is a placental substrate which have properties like that of thyroid stimulating hormone. Estrogen, progesterone, the fetus and placenta interact as a functional unit. called fetoplacental unit in the formation of estrogen and progesterone. In connection with estrogen synthesis during pregnancy, both the placenta and fetus cooperate with each other. Some enzymes are absent in the placenta but present in the fetus, whereas some are absent in fetus but present in placenta. But when two systems work in union, enzyme system is complete. The placenta synthesizes pregnenolone and progesterone from cholesterol. Some of the progesterone enters the fetal circulation and provides the separate substrate for the formation of cortisol and corticosterone in the fetal adrenal glands. Some of the pregnenolone enters in the fetus, and along with pregnenolone synthesized in the fetal liver is the substrate for the formation of dihydroepiandrosterone sulfate, that is DHEAS, and 16-hydroxy dehydroepiandrosterone sulfate in the fetal adrenal. The DHEAS and 16-hydroxy DHEAS are transported back to the placenta, where DHEAS forms estradiol and 16-hydroxy DHEAS forms estriol. Since fetal 16-hydroxy DHEAS is the principal substrate for the estrogens, urinary estriol excretion of the mother can be monitored as an index of state of the fetus. So this is a diagram showing the fetoplacental unit where placenta is able to produce pregnenolone and progesterone uh, from the cholesterol, and these pregnenolone and progesterone, they are transferred to the adrenal cortex. They gets converted into DHEAS and 16 hydroxy DHEAS, and from the progesterone they'll be able to produce cortisol and corticosterone because they have a needed enzymes in the fetal adrenal, whereas uh, the placenta helps in the production of estradiol and estradiol, which they are going to use the DHEAS as a substrate which are produced in the fetal adrenal. So thus the fetoplacental unit helps in the production of estrogen and progesterone mutually. Note that increase in the uptake of oxygen with fetal blood as it traverses the placenta due to the double bore effect, because while flowing through the placenta, the PCO2 of the blood decreases and its pH increases. This shifts the oxygen hemoglobin dissociation curve to the left to cause increased loading of oxygen, and PCO2 of the maternal blood increases as its pH decreases. This shifts the oxygen hemoglobin dissociation curve to the right and causes increased unloading of oxygen. Coming to parturition. Parturition means birth of the baby. Towards the end of pregnancy, the uterus becomes progressively more excitable until finally it develops strong rhythmic contraction so that baby is expelled. The process of parturition is divided into three stages. The first stage is dilatation of the cervix, second phase is expulsion of the fetus with membranes, and third phase is expulsion of the placenta from the uterus. The first stage, that is initiation of the labor. Initiation is usually indicated by the appearance of labor pains, which are due to the conversion of slow and rhythmic uterine contraction, that is Braxton Hicks contraction, to a strong and powerful contractions. These contractions become stronger at full term and force the baby uh, through the birth canal, thereby causing parturition. Mainly two categories of effects lead up to intense contraction responsible for parturition, that is the hormonal factors that increases the excitability of the uterine musculature and the mechanical factors that increases uterine contractility. Hormonal factors which are responsible: there is increased ratio of estrogens to progesterone. The high estrogen to progesterone ratio sensitizes the uterus to stretch prostaglandins and oxytocin. The estrogen has a definite tendency to increase degree of uterine contraction as they increase the number of gap junction between adjacent uterine smooth muscle cells. From the 7th month of pregnancy, estrogen secretion continues to increase while progesterone secretion remains constant or even decreases slightly, and thereby maintaining a high estrogen progesterone ratio. Then the effect of oxytocin on uterus. Oxytocin appears to play a prominent role in the process of parturition. It facilitates parturition by causing contraction of estrogen primed uterus. The uterine muscle increases its oxytocin receptors near term, and also the rate of oxytocin secretion by neurohypophysis uh, is considerably increased at the time of labor. Then the effect of fetal hormones on the uterus. The fetal pituitary gland secretes increasing quantities of oxytocin and uh, plays a role in exciting the uterus. The fetal adrenal glands secrete large quantities of cortisol, which is uterine stimulant. The fetal membranes release prostaglandins in high concentration at the time of labor, which increases the intensity of uterine contraction as well. Some of the mechanical factors which are related to parturition are stretch of the uterine musculature, that is, uterine muscle is being a visceral type of smooth muscle, contracts when stretched. The sensitized uterus, when stretched by the fully developed fetus, brings out powerful contraction. And second is stretch of or irritation of the cervix. Stretching of the or irritation of the nerves of the cervix initiates reflexes to the body of the uterus, which may result in a powerful contractions. So this is how the parturition occurs. Mainly occurs because of the body is pressed against the cervix, and there will be cervical dilatation. How the parturition is going to be initiated, and further cervical dilatation causes the stimulation of the hypothalamus, which increases more amount of oxytocin from posterior pituitary, which reaches the uterus and acts on the uterine muscles to increase the contraction of the uterus, and also they release prostaglandins, which acts on the uterus and the cervix for the cervical, which facilitates cervical dilatation. And for the cervical dilatation, it makes a passage for the baby to enter into the vaginal tract, and when the baby enters into the vaginal tract, that impulses from the vagina goes to the hypothalamus. Again, they will increase the secretion of oxytocin, so ultimately that will lead to the expulsion of the baby. Coming to lactation. Lactation is the process of milk output from mammary gland. It is divided into two stages: the stage of secretion and ejection. Milk secretion. Initiation of milk secretion is called as lactogenesis. After expulsion of placenta, there is a decline in estrogen and progesterone. The drop in estrogen initiates lactation. Estrogen at low levels probably helps milk secretion by inhibiting prolactin inhibiting factor, that is PIF. Prolactin secretion increases during breastfeeding. Maintenance of secretion is called as galactopoiesis. This is the function of prolactin, mainly with the aid of other hormones. Effect of lactation on menstrual cycle. Women who do not nurse their infants have the first menstrual cycle 6 weeks after delivery, and women who nurse regularly have amenorrhea for 25 to 30 weeks. Nursing stimulates the prolactin secretion, which in turn inhibits GnRH secretion, and thereby ovulation is inhibited. Milk ejection is nothing but expulsion of the formed milk from the gland, and it is possible because of the suckling action of the baby and the contraction of the myoepithelial cells by oxytocin secreted from the suckling reflex, and it occurs because of the continuous production of the milk creates a positive pressure which pushes the milk out. Suckling reflex is a neuroendocrine reflex. When the baby suckles the nipple, it causes stimulation of the tactile receptors of the areolar region of the breast, which activates somesthetic neural pathway, which is transmitted to the paraventricular nuclei of the hypothalamus, which leads to oxytocin secretion from the posterior pituitary, which reaches the mammary gland through the blood, and it leads to the contraction of the myoepithelial, which causes ejection of the milk, which is also called as milk letdown reflex. So when baby suckles the nipple, the impulses are going to reach to the hypothalamus, which stimulates the posterior pituitary to release oxytocin, which causes contraction of the myoepithelial cells, and breast milk is expressed into the mouth of the baby, and that is going to initiate the suckling reflex, and the cycle continues. So this is in brief about the pregnancy. Thank you.